How much does management consulting help nonprofit hospitals? Does adding intra-arterial Alteplase after successful thrombectomy improve outcomes for acute stroke? What are the outcomes among survivors of opioid overdose in the fentanyl era? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, May 8th, 2026. I'm Dr. Linda Brubaker, JAMA Deputy Editor, sitting in for Dr. Bibbins Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today, I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hey, Preeti. Let's start with a question many people are asking. We know management consultants are expensive. Is the high price justified?
Great question, Linda. The first research article published this week is an observational study by Dr. Brew and colleagues. The authors looked at 306 U.S. nonprofit hospitals that hired a management consulting firm for the first time between 2010 and 2022 and compared these hospitals with 513 matched hospitals that didn't use management consultants during the same time period. Nonprofit hospitals that hired management consultants paid an average of $15.7 million for services, and collectively, nonprofit hospitals nationwide spent nearly $8 billion on these services over 14 years. But after all that investment, the study found little evidence of meaningful improvements in finances, operations, or quality of care attributable to the engagement of consultants. Financial margins, patient outcomes, and operational metrics among these hospitals engaging consultants looked virtually unchanged compared with control hospitals. These findings challenged the assumption that outside experts reliably add value for hospitals and suggest nonprofit health systems should take a hard look at why and how they engage management consultants.
The editorial by Buckmuller and Levy note that using consultants is often a sign of growing administrative complexity in healthcare, but there's wide variability in how hospitals deploy these contracts and no one-size-fits-all approach. The key takeaway? More research is needed to pinpoint when consultants add value.
Linda, let's talk about acute stroke care and whether clinicians should deliver adjunctive intra-arterial Alteplase after achieving recanalization with thrombectomy. The CHOICE-2 trial by Dr. Renu and colleagues, an open-label randomized control trial performed at 14 stroke centers in Spain, randomly assigned 440 patients who had acute ischemic stroke with large vessel occlusion, all of whom achieved successful thrombectomy. Half of the patients received adjunctive intra-arterial Alteplase and half did not. At 90 days, 57.5% of those receiving that extra Alteplase achieved an excellent functional outcome, defined as a modified Rankin scale score of 0 or 1, compared to 42.5% in the thrombectomy alone group, which was the primary outcome. That's an absolute difference of 15 percentage points. Among secondary outcomes, residual hypoperfusion rates were also significantly better among those given intra-arterial Alteplase, and there was no significant increase in symptomatic intracranial hemorrhage. However, the group receiving Alteplase had a higher 90-day mortality, 12% versus 6%. So while functional status at 90 days improved without a significant increase in symptomatic hemorrhage, the unexplained higher mortality suggests we need more evidence before routine use.
The editorial by Fisher and colleagues echoes that note of caution. They acknowledge the clear functional benefit, but point out that increased mortality, uncertainty about the imaging findings, and narrow generalizability all mean CHOICE-2 isn't a practice-changing trial for now.
Staying on the topic of stroke, the TNK Plus trial by Dr. Shang asked whether bridging thrombolytics with Tenecteplase before endovascular treatment improves outcomes in patients presenting 4.5 to 24 hours after stroke onset due to a middle cerebral artery occlusion. This multi-center randomized trial was conducted at 40 centers in China and included 391 patients. Half received Tenecteplase before thrombectomy, and half went straight to endovascular treatment. After 90 days, functional independence was achieved in 44% among the Tenecteplase group versus 43% in the direct endovascular treatment group, with no difference in mortality. Symptomatic intracranial hemorrhage was higher with Tenecteplase, 5.1% versus 2.6%. The key conclusion? In this population, presenting 4.5 to 24 hours after stroke onset, giving Tenecteplase before thrombectomy did not improve outcomes compared with endovascular therapy alone.
Another trial on acute stroke is the INSTANT randomized trial by Dr. Zheng and co-investigators. The authors conducted a double-blind, placebo-controlled trial across 37 hospitals in China to assess utility of intravenous Tirofiban among 359 patients with acute ischemic stroke without medium or large vessel occlusion or cardioembolic etiology and an insufficient clinical response to Tenecteplase. Tirofiban is a rapidly acting glycoprotein 2B3A inhibitor with a short half-life and offers a promising pharmacological profile for early intervention. Participants were randomly assigned to intravenous Tirofiban or placebo, both followed by oral antiplatelet therapy. At 90 days, an excellent functional outcome, defined as modified Rankin scale 0 to 1, was seen in 64% of the Tirofiban group versus 52% with placebo. Mortality was similar, and the rate of symptomatic intracranial hemorrhage was low in both groups. For this selected population, early intravenous Tirofiban may offer an added chance at full recovery without major safety concerns.
Switching gears, a research letter by Dr. Kleinman and colleagues reports sobering numbers on post-overdose outcomes in the fentanyl era. Using health data from Ontario, Canada, researchers tracked nearly 29,000 individuals discharged from emergency care after a non-fatal opioid overdose, most in geographic settings where fentanyl use is now widespread. During the one-year follow-up period, more than 21% experienced another overdose, and the one-year mortality rate was 8.6%, with about two-thirds of deaths due to opioid overdose. Prior overdose during the preceding 5 years was associated with an increased risk of mortality. These findings are an urgent reminder. Just surviving a fentanyl overdose doesn't ensure stability or safety, and tailored clinical interventions following emergency department discharge should be a priority.
In their Viewpoint, Drs. Davenport and Reeder consider the consumer phenomenon of direct-to-public commercial whole-body MRI screening for the general population. This screening is unproven, not endorsed by any major society, and comes with considerable risk for overdiagnosis, false positives, and unnecessary downstream testing. The authors caution, buyer beware.
In another Viewpoint, Dr. Karen and co-authors discuss a modern problem. What happens to the development of clinical expertise as AI systems take over more and more thinking tasks in medicine? They call for AI to be deliberately designed as a reasoning coach, not a crutch, and for medical education to find new ways to safeguard and measure authentic clinical thinking.
And in a perspective, Professor Lieberman and colleagues explore the conundrum of recommending exercise for weight management in the age of widely used GLP-1 receptor agonists. They note that while these medications can make weight loss easier, they don't replace the broad physiologic and public health benefits of regular exercise.
This week's Clinical Review offers a comprehensive summary of hepatitis B by Dr. Zheng and colleagues. Hepatitis B virus infects more than 250 million people worldwide and causes around 1.1 million deaths annually. The review details the spectrum of acute and chronic disease, current approaches to diagnosis, and evidence-based strategies for treatment and prevention. Listen to further discussion of this material in this week's JAMA Clinical Reviews podcast. Review author Dr. Anna Locke discusses how we screen for hepatitis B with JAMA Associate Editor Dr. Beverly Forsythe. Here's a clip of their conversation.
Well, it's a simple blood test, and to screen for infection, we'll test for hepatitis B surface antigen. But we also want to know whether someone has immunity or not. And for that, we test for hepatitis B surface antibody. Because in the US, we expect that very few people would test positive for infection. But knowing whether they have immunity is also important because we can then recommend them to get vaccinated. The third marker that we would test for is the hepatitis B core antibody. That actually helps us determine whether someone had been exposed to the virus before, because they may have been exposed, they may have a transient infection, and they've recovered from it, so they now have surface antibody and they have core antibody. They're okay, except if at a later stage in life, if they require very potent immunosuppressive therapy, like cancer chemotherapy, and nowadays so many biologics for all sorts of medical conditions, if the immune system is suppressed enough, the virus might still become activated.
The JAMA Insights by Dr. Dubé covers anterior cruciate ligament, or ACL rupture, a common sports-related injury. This article reviews surgical versus non-surgical management, as well as other rehabilitation and surgical considerations.
And as always, the JAMA Medical News Team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.